Okay, now I'm ready. And we can move this way out of the way. And get away. Here. Oh. It's trying to record my voice, which I'm already recording. I don't need to record twice. Okay, so we left off talking about a pneumothorax, and I was explaining, I took time to explain what it really is, and I showed you a video. And then we talked about the treatment, but I didn't show the treatment of inserting in the chest tube. So this video will do that. And again, I don't know if the volume's on, but it's not a big deal. Stupid ads. Okay. Skip. Okay. Is there volume to this at all? It could be that thing. It's not turned on. It's okay. We don't need it. All right. So they're just talking about, maybe big so you can see it. This thing is such in the way. So here they got a little baby. You think of a baby having pneumothorax, but okay. So this is the intrapleural space that's being filled with air. So the previous video I showed went over that. And so let's jump ahead a little bit. I don't know if I can. I think I can. Okay, they're just talking about gas exchange at the lungs. Then they're talking about the pneumothorax, so we're about right. All right, so chest tube. So again, this is usually done on someone. It's an emergency. They don't usually take time to sedate a patient. They just go right on in there. All right, they'll numb the area where they put the chest tube in with some lidocaine or something like that, but they need to get that air out so that the pressure from the air entering the lungs is enough to expand the lungs against the thoracic cage again and make it stick. All right, that's if it's not a surgical fix, but that's the chest tube. All right, okay, so we don't need to watch more of this. Move. There we go. All right. Now, this third video, technically, they take a set of lungs with the trachea still attached, and they put, I keep calling it an ambu bag. Zachary, what's the name of that bag again that you used to inflate? It's a Dr. Tolson gave it to us, and I didn't write it down. Anyway, it doesn't matter, but they use that to inflate the lungs. And what they've got the lungs in is a fake parietal pleural. They use a plastic bag or like a grocery bag or, garbage bag or something like that to demonstrate what happens when normal lungs, where there's no hole in the lungs or anything like that, inflate and recoil, inflate and recoil. The parietal pleura, the garbage bag, moves with it. And then they'll show you a set of lungs where they've got a rent in it, which is a tear in the lungs. And so every time they compress the bag and force air into the lungs, air escapes out the tear and starts filling the space between the visceral pleura on the lungs and the parietal pleura, which in this case is the garbage bag. And then you start to see a whole big air pocket form. And then that air pocket is supposed to represent the pneumothorax. So I thought that was a pretty ingenious way of them to show it. So we'll see if we have volume here. Yeah, it's still off, but it doesn't matter. Oh, there. So these are normal lungs without any tears. And there's that bag we used in the CPR class. Your CPR card should be arriving. So that's supposed to be the parietal pleura. And notice when the lungs expand, it does. When the lungs recoil, it does. Hold on, let me pause it. What was the question? Were we supposed to print our own CPR cards? You can, yes, you can print out your own CPR. They're, if you bring me, and you can print it out in black and white or color if you want, whatever you want. Black and white's fine. But if you bring it to me, and we can talk about this more later, I have a laminator. So the next time that we are in lab, which I have more time, all right, I can laminate them for you. So when we have that blood physiology lab, there's no quiz, the lab reports are due. If you bring your cards up while you're doing the lab, I can run them through the laminator and that'll keep them more protected. Yeah. All right. Okay. Oop. Okay. So now we've got a set of lungs that has a tear in it. All right. So now they wrap it in the fake parietal pleura. And every time they squeeze that bag and force air into the lungs, some of that air is escaping out the hole and starts to fill that intrapleural space. So it shows you how quick a pneumothorax can happen. So see, that's not supposed to be there. It's supposed to expand, recoil, but it's not. Oh, you've got a hole in your bag. Come on, get your act together. But basically that air pocket that's forming, that's the pneumothorax. And in a real physiological system, that air pocket will cause the lungs to deflate and collapse your lung. All right, so everyone understand that? You get a good kind of picture of it now? Okay. All right, so this is the clinical app that goes with it. It says, if air enters the intrapleural space, raises the intrapleural pressure, it's always supposed to be negative. It becomes positive, and the lung pulls away from the thoracic wall, and basically causes it to collapse. Really, it's the air pocket that's pressing on it that causes it to collapse. Okay, vocab. So surface tension, this thing's always in the wrong place, is the term given to the pressure or resistance from that thin film of water lining your alveolar sacs. That's called surface tension. That's why water bugs can walk across the surface of water, surface tension. All right. So the pro having the thin film of water is it allows gas exchange to occur better. But the con is that every time your alveoli expand, collapse, well, not collapse, expand, get small. When they get small, when you exhale, those walls could snap together like the 2 microscope slides, and it takes tremendous pressure to make them separate again. So since it's not here, what do we have in our alveolar sacs from type 2 alveolar cells that basically negates the surface tension so your sacs won't collapse when you breathe out? Begins with an S, surfactant. All right. Remember, we talked about that on Monday. I was talking about, especially in premature babies who come out not fully cooked and their alveolar cells are not producing enough surfactant. So whenever they breathe and then exhale, those sacs, when they shrink down with exhale, they could get stuck together. And when enough of those sacs get stuck, they collapse, the whole lung collapses. And I called it non-obstructive atelectasis. All right. So all vocab. Okay. Compliance. Compliance is when you inhale and that air comes filling into your lungs, and you saw with the healthy lungs, they push air into the bag and the lungs went. That's compliance. The ability of the lungs to stretch when air enters. All right, we'll talk about disorders of compliance, several of them. Okay, so the lungs have to be stretchy to be able to expand. That means the lung tissue has to be healthy. It can't have scar tissue or anything like that, because scar tissue is not going to expand and stretch like it should. So compliance is when you breathe in, your lungs go like that. Now, recoil, and it's also known as elasticity, but I don't like using that term because when I explain compliance, it has to do with the stretchiness of your lungs to be able to inflate when you take air in. Now, when you exhale, the lungs collapse back down. Well, not collapse, but they recoil. They attain their original shape. Think about a balloon when you blow it up, right? When you let the air out, the balloon returns to its original shape. And it has compliance. When you force air into it, the balloon expands. And then when you let the air out, it goes back to its normal size. That is recoil. The lungs are bouncing back, all right? So those are important properties of the lungs, and we'll talk about that. Especially, I'll use all these things, surface tension, compliance, recoil, when I talk about respiratory disorders. So that's vocab to understand the disorders. Okay. Okay. Is this working? No. Okay. So again, a little GIF, which it's not working now because I took too long to explain it. Yeah, it's not running. But basically, compliance is this. Expand. Recoil is this. Compliance, recoil. compliance, recoil. Same thing's happening with your alveolar sacs. They comply, recoil, comply, recoil. Okay. So factors that increase compliance, surfactant. All right. Emphysema. How many people have heard of emphysema? And I define it on the next slide. Right. My dad had it. It's not what killed him, but it was a collection. It certainly didn't help him. Years and years, decades of smoking. I'll show you some slides. All right. Emphysema is basically you have too much compliance in your lungs. There can be too much of a good thing. What happens is you take in something into your airways that acts as an irritant, a foreign body, like the other things in the cigarettes other than just nicotine. All right. Those things, when you get them into your lungs, into your alveolar sacs, all right, your sac is like this, they kind of settle in with gravity at the bottom of the sac. Guess what? Your immune system will try and mount an immune response to remove that debris, those artifacts, those, foreign bodies. But if you keep smoking or taking in those things, it's going to cause chronic irritation over time. And I talked about this process before. And chronic irritation can cause fluid to form. That's your body's immune response, mast cells releasing histamine. And also chronic inflammation can cause tissue to deteriorate. Think about arthritis, all right? Arthritis left untreated at your joints is chronic inflammation, and eventually that inflammation will cause the hyaline cartilage of your joints to disintegrate, and eventually it's just bone on bone. That can happen anywhere in your body, in your alveolar sacs. The walls of the alveolar sacs, they're very thin, I mentioned this, and chronic irritation can cause those walls to disintegrate. And that is exactly what happens in emphysema, and you end up with these large air trapping spaces, and it's called an air trapping disorder. All right, so I have this on the next slide. So smoking, move this thing again. All right, or anything where you take in foreign material into your airways and it stays there for a long period of time, causing inflammation. These particles settle in here and they tend to not come out. I mean, if you smoke for a couple of years and then you quit, your lungs are going to heal themselves. But if you go on for decades and decades, that stuff's going to stay there. So they never leave. They cause the chronic inflammation. Inflammation destroys the alveolar walls. They disintegrate. All right. And here we have normal walls between each cluster, like a great cluster. And here we have walls that have been lost from the chronic inflammation. They simply disintegrate. They're one cell layers thick. They can't handle much inflammation. So you have large air spaces within your alveolar sac system that trap air. So here's what happens. I'm going to try, and I've never found a video that shows it very well, but when you breathe in, you have no problem with compliance. They fill. But without the distinct walls around them, when you exhale, and they're supposed to reduce in size and expel that air, when you've got big air pockets, when you take in air, they expand. But when you try and exhale and evacuate most of that air, they can't. Some air remains trapped. So here's what happens. You take in a breath of fresh air with oxygen. Then you try and exhale to get rid of the CO2, but not all the CO2 can be eliminated because the alveolar sacs don't recoil because they've lost their walls. So some of that CO2 remains in your lungs. You take another breath in. There's already some CO2 still left in those sacs. So there's less room for new oxygen. And then when they recoil, again, you're not getting most of the air out. So you're always a little bit oxygen deprived. So if you see people walking out, there's many respiratory disorders, but people with bad emphysema, they're the ones you see walking around with little oxygen tanks and the mask or the little nose cannulas, because they need a higher concentration of oxygen delivered to the respiratory system than is found in the atmospheric air because they're oxygen deprived. All right. So I can't imagine what that would feel all the time. You'd be winded because you just don't have enough oxygen, very difficult to move around, can't tolerate any kind of exercise. So how many people have seen someone walking around with those little oxygen tanks with the, common, all right? So that's what's going on with emphysema. So smoking ain't the only thing that can cause the deterioration of the alveolar sac walls. Vaping, all right? So actually, I'm not going to show it, but I've got a link here to this study, American Journal of Respiratory and Critical Care Medicine. So pretty good journal. talks about University of North Carolina, just to our north. Scientists found that the lungs of people who vape have elevated levels of protease enzymes. And this article talks more about it. Protease, it ends in ASE, so it's an enzyme, protease. What's this enzyme breaking down? Protein. What are the walls of your alveolar sacs made of? Protein. Okay. And so this is something that they also find in the lungs of smokers, elevated protease enzymes. They're finding it also in the lungs of people who vape. So it's still a relatively new thing. Probably in another 10 years, we'll get a lot of studies showing what are the long-term consequences of vaping. So people think I vape because it's safer than smoking. Well, that might not necessarily be true. You might not be taking in all the extra things that are found in cigarettes, and some pretty nasty stuff, by the way. But just whatever they've got in the vape, it's still elevating these proteins, protease enzymes, which could hypothetically, if they're there over time, break down the alveolar sac walls. And so I don't know. I just found the study and I thought it was interesting. So we'll see what the long-term effects are. Okay, this one. If you have someone in your life that is a chronic smoker and you want to try and get them to quit, you might want to show them this. I mean, but still, I talked to my father till I was blue in the face. And he had one scare. He found he was coughing and he had emphysema. He knew it. They knew it. They diagnosed him with it. And he had an x-ray and they found a spot on his lungs. And he was like, oh my God, it's lung cancer. Turned out it was nothing. So he stopped smoking for a while because he was scared. When he found out it was nothing, guess what he did? Went right back to smoking, okay, which is the sad reality. But any foreign material that you take into your lungs over a long period of time, not just cigarette smoking, can cause that chronic inflammation. And it could break down alveolar sac walls, leading to emphysema. But the other thing that can happen, I mentioned it before, any tissue in your body, whether external or internal, that's chronically inflamed, and you don't stop it or treat it, eventually that tissue is going to try and repair itself by putting down scar tissue. Scar tissue. Remember when I talked about blood physiology, I talked about platelets and fibrinogen and the fibrin threads that knit a wound together. Okay. That's a scar. That's scar tissue. All right. So those fibrin threads, the body's trying to repair itself. But once scar tissue forms, that's it. It's permanent. Once your lungs form scar tissue, it's permanent. Okay. So I'm going to talk about pulmonary fibrosis, where the fibrin threads have been laid down to repair chronic inflammation. Once that happens, pulmonary fibrosis, permanent lung damage. You're not going back from there. So when I was talking about compliance, recoil, compliance, recoil. The compliance, if your lungs are scarred, I guess trying to inhale and expand your lungs, you know what a python does, right? The snake that's a constrictor. It wraps itself around a body and it starts contracting, and you can't, it kills its prey by asphyxiating them. They can't expand their lungs to breathe. They have no compliance. That's what it would feel like to have pulmonary fibrosis. So this is what it looks like. On the right, they're going to have healthy set of lungs that when they inflate it with the bag, compliance, recoil, compliance, recoil. And then they have the smoker's lungs, and obviously either this person got a double lung transplant or they didn't make it. You'll see the difference. So hopefully this comes up here. There we go. I've got two of them running. Okay. There we go. So healthy smoker's lungs. Yes, they got the bag going into the trachea, and we have compliance, recoil, compliance, recoil, compliance, recoil. All right, that's what it should be. But then when you've got pulmonary fibrosis, and yes, they do get tar buildup, and that's not good compliance. This one's not even complying at all. Right. That's pulmonary fibrosis. Permanent damage. Right. Okay. All right. So does that give you a nice pictorial of what's going on to the lungs? And so I'm not just knocking on smokers. You could inhale particles from another source, and we'll talk about silicosis and things like that. But yeah, that's a pretty scary video. Okay. So factors that decrease compliance, the ability of the lungs to stretch, right? Anything that causes chronic inflammation can lead to decreased compliance. Pulmonary fibrosis. So think of those lungs. They can't comply. They should comply, but they're like, you know, you're basically feeling like you can't breathe. So pulmonary fibrosis is the end product of chronic inflammation that has been left untreated or stopped over time, leads to scar tissue, pulmonary fibrosis. So smoking, certainly up there. All right. Okay. So, all right. So let's talk about the disorders. And I've included the ones that I think you're going to see, the common ones, the big ones. There's so many, I can't possibly cover them all. But restrictive disorders are when the lung tissue has been damaged. Okay. The lungs are stiff or your respiratory muscles are weak. Here's another thing that could be a restrictive disorder: myasthenia gravis. Oh, you remember what that was? I covered it in the muscular system. Autoimmune attack on acetylcholine receptors on your skeletal muscles, smooth muscle, heart muscle. Okay. Left untreated, this autoimmune disorder, eventually it goes after the respiratory muscles. It's called myasthenic crisis, is when your respiratory muscles are now so weak from loss of receptors that your respirations are weak. People get admitted, they get intubated, go on a respirator, it's bad. Okay. But pulmonary sarcoidosis, which is something new I covered, lung cancer damages, destroys the lungs. All right. And then this infant respiratory distress syndrome it's included under restrictive disorders and acute respiratory distress syndrome. I'm more inclined to focus on this one. Oops. Because when I think of that, let's see what my pen is doing. Come on. Oh, well, it's going to have to be red. Think about COVID. All right. Some people got COVID. They recovered, especially if you're young and healthy, have no underlying conditions. How about older people or people who are immunocompromised or have other things like diabetes or obesity or something? They recover less. In fact, they're more inclined to have long COVID, which is they have respiratory problems that persist for months, if not a year or more after having COVID, indicating that the lungs were permanently damaged from that event. Okay. Now, obstructive, the lung tissue is normal to start with. Okay. But resistance is increased. The airways are narrowed. So think about maybe the bronchioles. Right. So air tends to remain in the lungs even after exhaling because the bronchial diameter is narrowed. The classic one is asthma. And that's what happens in an asthmatic event is you have such inflammation in your airways that they swell and now they narrow because of the inflammation. COPD, anyone know what it stands for? Because I see commercials for it on TV all the time. Chronic obstructive pulmonary disease. Okay. So it implies that it's chronic. Within the umbrella of COPD is emphysema and chronic bronchitis. It's kind of held within that category of COPD. And also cystic fibrosis, which is common enough that I'll include it. I had chronic bronchitis as a child. Fortunately, I outgrew it, but I didn't have asthma. It wasn't that, but I was exposed to something. My airways would get inflamed and they'd narrow, and then I'd have a hard time breathing. Up where I live, and I mentioned the air was cold in the wintertime, that would trigger it. They get inflamed because the air is so cold. It's very irritating to your airways. And what your bronchioles are doing is trying to protect you from this irritant. In this case, it was cold, and they'd constrict to narrow the entry of that air, but that's narrowing the entry of the air getting in. And so you can't breathe. I literally felt like I was suffocating. I was like just ready to call EMS at any time. All right. Asthma. Anyone here have asthma? Have you had an asthmatic crisis where you have to use the rescue inhaler? No, that's fortunate. Dr. Pryor suffered from asthma for many years, and I've seen many a time where he wakes up in the middle of the night, uses his inhaler because he can't breathe. It's terrifying when you can't breathe, when your airways close up like that. Okay, so pulmonary fibrosis. Let's see if I can change my ink color. Nope. There we go. I want to move you. Can I move you to the side? No, it won't let me. So won't let me change my ink color very easily, so it's going to be red, is scarring of the lungs. And that means the alveolar sacs from chronic inflammation. Okay, scar tissue gets put down. Once that happens anywhere in your body, that tissue is never going to be the same again. I mean, your body saved itself kind of by putting down scar tissue, but that's going to lead to problems. Okay, so that once you have the scarring of the lungs, that's your lungs can't fix that. Okay, so there's many, many things that can cause this chronic inflammation that leads to the scar tissue. So smoking, all right, you inhale foreign particles. If you ever looked up what's inside cigarettes, all right, I wish this thing would go out of the way. You're just inhaling foreign particles into your airways that cause the chronic inflammation. Over time, your lungs have no choice but to repair themselves with scar tissue. Silicosis. Okay, this is inhaling small particles of sand, stone, I won't say fiberglass. Okay, and each one of these can lead to this. What I'm getting at is each one of these can lead to that. It causes irritation, chronic irritation. Over time, your lungs have no choice but to lay down scar tissue to repair themselves. Anyone out here mow their lawn? Do you have a lawn? You watch your parents mow their lawn, right? Do they wear a mask? If it's a big lawn, they should. If they're out there mowing for an hour, they should be wearing a mask. Do you know why? That mower is obliterating grass particles, but also soil, small particles of soil. It's aerosolizing it all around you as they're going around mowing, right? They're drinking their beer, they got their headphones on, right? And like, hey, you're breathing in that stuff. How do I know how bad it is? Well, I have a lot of property and I mow these walking paths for me and my dog. So I'm on the mower for a good hour. You know, I'm wearing my shorts and t-shirt and I've got my ear protectors on and all that stuff. And I wear a mask. When I get done, I look at myself and I'm all dust. I'm all dust. My mask, my face, I can take a washcloth and it's just all dust. If you're not wearing a mask, that's going in your airway, okay? It does the same thing, causes the chronic inflammation, which after decades could lead to silicosis. So when I see professional landscapers wearing a mask, I'm like, right, good. Okay. Anthracosis, black lung disease, breathing in coal dust. So this is the black lung disease of coal miners. So if the mine doesn't collapse or run out of oxygen, if that doesn't kill you, a lifetime of coal mining, you breathe in all that dust, you get the black lung disease. Now, anyone know what mesothelioma is? Because sometimes they show a lot of commercials late at night.
Does it come from asbestos? I can't remember.
Yes, it comes in from breathing in asbestos. And it can lead to, in fact, any of these lung cancer, but mesothelioma technically is the term given to lung cancer from time spent breathing in asbestos fibers. Asbestos is made of like fiberglass fibers. So there's small fibers and little glass particles in it, and it basically adds insulation to buildings.
How long does it take? Because I mean, I went to military school, we go to this old band hotel.
It takes decades of exposure. One of the reasons I moved out of the offices in MSB is the oldest original building of the science building. LSF is the new one. LSF doesn't have asbestos as their insulation. MSB does. And so I'm like, I don't feel like spending a couple decades of my career in this office. I'm down here now. All right. And it really isn't a concern unless the walls are disturbed or construction is done. They have done renovations on LSF. They haven't done them on an MSB because they need to get all the hazmat stuff in, plastic barriers, because if they disrupt the wall and release asbestos, people breathe in. Okay. So every one of these things can lead to pulmonary fibrosis. Pulmonary fibrosis can lead to cancer. Let me explain this to you. Okay, it's a process. Remember when I was talking about atherosclerosis, cholesterol buildup within your arteries that narrows them, and that could lead to a thrombus forming. That could lead to an embolism. That could lead to a stroke, or that could lead to what else would happen? An artery becoming weak and swelling, an aneurysm. All right. So one thing starts, and then all these things can happen. So these things and many other things, you take in these air particles that cause chronic inflammation over a long period of time. You get scar tissue. Well, scar tissue is basically your body repairs tissue by mitosis. That's how our cells grow and repair themselves. And pulmonary fibrosis is your body's response to repair tissue by mitosis. Anytime you have a chronic inflammation in your body and your body's trying to repair it by mitosis, eventually you're going to have a mistake in mitosis, which is cells dividing out of control, which is cancer. So any kind of chronic inflammation can become cancerous because it's mitosis repairing the tissue. And if it's having to do over and over and over and over and over, eventually there's going to be a mistake, and that could be cancer. Can you understand how this problem can lead to this and they can lead to that? Right. Not something you get in your traditional biology classes, but since I'm very familiar with cancer, I've learned a lot about it. Okay, are we good on this? Okay, so again, this, if I wasn't told this was pulmonary fibrosis, I would say this is someone with COVID or this is someone with pneumonia. They all look the same to me, but I'm not an X-ray technician. There's people out there who know exactly what they're looking at. Okay, pulmonary sarcoidosis, which I included under restrictive. More rare, so this might not be seen very often, but you form small patches of swollen tissues called granulomas in your lungs. So these are the things that can cause it. If you breathe in bacteria, all right, so it can be found associated with pneumonia. Viruses. So the flu I heard is particularly bad this year, and the onset is now. So get your flu vaccine. Or chemicals, breathing in chemicals that irritate your lungs. So if you're working in some place where you're breathing in chemicals all the time, like cleansers, or especially in an enclosed space where there's not good ventilation. All right. So these can lead to basically an inflammatory event where you've developed swollen granulomas throughout your lung. Anyone ever heard of sarcoidosis before? Yeah, it's because it's on the more rare side. Okay, let's get to it. Lung cancer. I just had a friend of mine die last summer from it. He was a smoker. He ended up quitting, apparently not in time. So lung cancer, here's the categories. Non-small cell lung cancer. That's the majority of all cancers. And then there's 3 subdivisions of that. And then there's this one, which is more rare, but more deadly. I don't know which one my friend had. But anyway, so adenocarcinoma, that's the majority of all of these cancers. Squamous cell cancer, so pretty high still. And then large cell carcinoma, 15%. Okay, so I got a nice pie chart here. You're going to see lung cancer. It's a common one, okay? It could, there's cases of lung cancer, someone who's never smoked, ever. It could be just like a spontaneous thing. But of course, long-term smoking. We'll see if long-term vaping gets added to this. Long-term exposure, like silicosis, mesothelioma, all those anything that can cause chronic inflammation can lead to cancer because of the pulmonary fibrosis. Okay. So the first one of the non-small cell lung cancer, the 40%, all right, it starts in the mucus-making gland cells lining your airways. Remember at the beginning of the chapter, I said you have in your airways fine cilia, hairs, and mucus that help trap particles so you can expectorate them out, right? This is where these cancers start. So they're trying to show right here, these things right here. All right, so there's your trachea, and then somewhere here in your bronchi. The good thing about this cancer is that it's more likely to stay in the place that it started. All right, that's called in situ. It doesn't metastasize easy. All right, and it's pretty easy to see on an X-ray. All right, so here we have that tumor cell. These are the mucus producing cells and the cilia right there. And here's that cancer starting out. They tend to stay localized. The bad ones are when they easily metastasize, but this is kind of not that category. If you want to read more about them on your own, I've included some links, but so mucus cells, it starts. Squamous cell, second most common lung cancer. It's the squamous cells lining the inside of your bronchi, all right? They're often linked to a history of smoking. The one saving grace, it's slow growing. It's not rapid, okay? But if someone gets an X-ray and they find, spots on the lungs, they have to go in and they have to biopsy. I assume they're doing that by like an endoscopy procedure. If they catch it early, your likelihood of survivorship is increased. All right. So people who are in your lives that are smokers, have been smokers for a long time, kind of encourage them at one of their health checkups with the doctor to get an X-ray just to kind of see if there's anything brewing in there, because catching it early saves your life. Okay, so squamous cells lining your airways. Large cell carcinoma, any part of the lung. All right, it can spread quickly, which makes it harder to treat. So again, any chronic smokers in your life, they should be getting X-rays every now and then, because the sooner you catch them and you can find out what they are, and then you can treat them. All right. So this is 15% of lung cancers, but it's kind of a bad one because it can happen anywhere and it's going to spread fast. All right. Okay. So that leads to the last one. Okay. Here's kind of comparing all three of the non-small cell. Most common, 40% adenocarcinoma, squamous cell, 30%. Begins in the bronchial tubes. Large cell, 15%. Okay. They don't say it does good, grow rapidly. All right. Okay, now this one is the terrible one. It's the most aggressive form of lung cancer. Starts in the bronchi, like many of these do, except for the one that forms in the squamous cells. In the center of the chest, so centrally located. All right. The cancer cells are small. That's why it's called small cell lung cancer. Since they're small, you can miss them on an X-ray. And if you miss them, then they could go untreated. And that's why the survivorship is so much lower for these. All right. Once they become large tumors, you can see them on an X-ray, but by that time, those small cancer cells have probably spread from the site where they formed, and that's called metastasis. They can go down to your bones, they can go up into your brain, they can all over the body, and that's bad. So you do not have to memorize this. This is just trying to give you an idea of the danger of these. So the 5-year survival rates for the non-small cell lung cancer, so adenocarcinoma, squamous cell carcinoma, large cell carcinoma. So if it stays where the cancer formed, it does not spread. That's a pretty good survival rate if you catch it and treat it. Okay, that's why adenocarcinoma is, I guess, the better one to have, because it tends to stay put and not spread so much. Once it is spread, okay, let's say cancer cell was here and then it spread to here. Now it's regional. It spread from the site from where it formed, but not far. Half, no, a little more than half of 5-year survival rate once it starts spreading. If it's distant, this is metastasized. Once it's gone, hit your circulatory system or lymph system, could be anywhere. All right. And then that goes down to an awful lot lower. All right. Catching it early saves lives. All right. So I'm saying this to you guys as nurses because you have someone who's coming in, chronic smoker, have emphysema. And the doctor says, well, maybe we'll send you in for a scan. And I don't need a scan. But if you have something and we catch it early, your survival rates are going to be greatly improved. I'm a big proponent of screening for cancer because that's why I'm alive. All right. I got my regular screening. I caught it early and my survivorship is like 95%. All right. Now this one, even when it stays where it was found, it hasn't moved, that's still pretty low. If it spreads just a little bit, all right, about half. And if it metastasized down to 3%, you're not going to survive that. Okay. All right. So that was all the restrictive disorders. How we got a little bit of time to continue, but any questions about that? I know I spent time, but you're going to be spending time with your patients. You're going to be the one who's talking to them, trying to talk some sense into them. If they fit a high risk category, chronic smoker, they've got emphysema, they're coughing, they, maybe do spirometry, their airflow isn't very good, you really should probably think about going for a scan, and then you can kind of talk to them a little bit about it. Okay. Obstructive disorders, the tissue starts out normal and the airways have been narrowed or resistance is somehow increased. So asthma, okay? And I go through a slide, each one at a time after this. We won't get to all of them, but asthma, COPD. Oh, why is my pen so small? Chronic obstructive, and so it's got the word obstructive in it. Pulmonary. And it could be disease. I've also seen it disorder. It's still a D. Okay. So it says chronic. So it's chronic. It's obstructive. There's more resistance or narrowing of your airways, and pulmonary, it's in the lungs. This includes emphysema and the chronic bronchitis. So let's start with asthma and we'll see how much time. Oh, I guess I started with the COPD. Okay. Whatever the reason that causes it, okay, your airways become narrow. The chronic inflammation destroys the alveolar walls. Your alveolar cells try and put out a bunch of mucus to try and expel or trap whatever particles are causing it. The chronic inflammation leads to scar tissue. That's pulmonary fibrosis, right? The mucus that's building up from here narrows your airways. So again, I said your upper airways produce mucus to protect yourself, trap, and help expel whatever irritant you've taken in. So chronic inflammation, first of all, the tissue inside your airways swell. If they also accumulate mucus, they're narrowed even further. And if they accumulate mucus, down the line, you could get pneumonia. So there's many things going on. All right. So just know it's obstructive because the airways have been narrowed from inflammation and also from a lot of mucus building up. All right. That's why it's obstructive. So asthma is the same way because the airways narrow from inflammation, and chronic bronchitis is in this because it's just something that causes an inflammation of your airways and they swell and they narrow. People who have the disorders of inflammation of their airways, what might they be prescribed to bring down that inflammation? This is just an applied question. I'm not writing it down. What can bring down inflammation? What's anti-inflammatory? NSAIDs, non-steroidal anti-inflammatories. But what about the steroid anti-inflammatories? Prednisone, right? Most commonly prescribed drug to bring down inflammation. All right. So these people might be prescribed steroid, prednisones, prednisolone, whatever, to bring down the inflammation. Okay. So this is here. If you want to read more about it, it talks about COPD. It talks about emphysema, air trapping. It talks about asthma may be treated on sustained basis with glucocorticoid drugs. No, there's a reason I had this in there. Those are steroids. It's a synthetic cortisol. It's anti-inflammatory. Oh, did I? You have asthma? Uh-oh. I cut updating. Oh, thank you. This is a blazing fast mouse and you touch it. Okay, thank you. See, I thought I have asthma first, then COPD. I didn't realize I'd skipped over it. Okay, so we'll end with this. All right. So asthma is inflammation of bronchioles from some exposure to an antigen. Okay, an antigen is something that triggers, I don't want to say allergic reaction, but something that triggers the inflammation. Inflammation is kind of an allergic reaction to something. Something triggers an asthmatic, all right? In Dr. Pryor's case, we found out it was having carpeting in our apartments, and carpeting, no matter how well you clean them, is always going to trap all kinds of pet dander and human sloughed epithelial cells. Gross to think about, but 98% of dust is your skin cells, all right? Things like that would trigger the inflammation that would cause the asthma attack. So what happens is the muscles around your bronchioles, we know our bronchioles can bronchoconstrict or bronchodilate. And as an immune response to this antigen, okay, I'll say, you do this, that triggers an immune reaction. This is not anaphylaxis or anything like that. It's just a normal immune reaction that, yes, it causes inflammation. And I include immune because I'm going to get to something here. So here's your normal open bronchioles. It looks like it's the primary bronchi. And here's the primary bronchi that have become hyperexcitable and they bronchoconstricted. So the resistance comes from the airways narrowed and it's harder to get the air in. I've experienced bronchoconstriction to a bronchitis event, and it is really scary. Like you can't like that. Kind of terrifying. Obstructive because of the inflammation. You get mucus secretion too, and the airways are narrowed. So, question: what drug would you give the treatment to dilate the bronchioles? Albuterol. Right? It's a beta-2 agonist. Good. Now, I don't have this written down anywhere, but you might have seen it on commercials. There's another way to treat. You can't live on rescue inhalers. Number one, eventually your body will build a tolerance and your bronchioles will no longer respond to it. That is a real thing. You build up tolerance. Another thing you can take, anti-inflammatories. That's prednisone or NSAIDs or something like that. There's also something else, and I'll put here, drugs to block eosinophilic white blood cell reaction. Back when I talked about blood physiology, I was talking about eosinophils. Never let monkeys eat. So it's not that common, but you'll see them with chronic conditions. You'll see them with parasites. You'll see them with chronic allergies. People with asthma have an immune system that's already kind of overreacting to common antigens in our environment. So you can open up their airways to rescue them. You can prevent the inflammation from happening. So they should be on anti-inflammatories. They can also be on drugs, which are relatively new, to slow down that eosinophilic response so the airways don't start constricting down. Has anyone ever heard of these drugs? Heard it on TV? Because I've heard of them. Okay, so it's actually 3 different ways to treat asthma. All right, so why don't we continue on with Friday? Have a good day. And the sign-in sheet started on that side of the class, so it's right there if you didn't get it.